Okay.
Stay close to the microphone.
All right, thank you very, very much. Thank you, President Daniels and Dean Clagg, and especially Andy Pekosh for organizing this really wonderful event. Today I want to talk about, excuse me, Ebola modeling for the immediate and long term. The fact that I use the phrase long term, of course, betrays a certain sobriety about this topic, and I will come back to that. Modeling, the things I want to cover in the talk are reasons to doubt the worst case estimate that has come out of the CDC. I want to also talk about why I doubt that Ebola will fade out completely. I expect endemic cycles are more plausible. And relatedly, I'd like to talk about why the outburst now. Why did we see this, and particularly this urban spike in incidence? I want to talk about an idea that I think is worth pursuing called mobilization of recovereds. I know that this faces some stigma problems, but I want to come back to those. Then talk about the global modeling we've done, look a little bit at the global side of things, and then talk about overall implications of the strategy. But first of all, I know that there's typically skepticism about models, so I wanted to just run a quick survey, an informal survey. How many people in the room are modelers? Wrong. I think everyone in the room, wrong answer, everyone in the room is a modeler. And when you close your eyes and imagine a process of any sort, an epidemic, the spread of democracy, a migration, an economic future, what have you, you're running some model. It's just an implicit mental model that you haven't written down. So the choice in life is not whether to model or not. You are modeling. The only choice is whether to do so explicitly or not. And explicit models have the advantage that they force your assumptions into clarity to yourself and to others. They permit you to explore the sensitivity of the results to those assumptions. They're replicable by others. They're comparable to data, can even tell you what data is worth collecting. So modeling has many aims and is conducted at many scales, and I will show you both toy models suggesting novel avenues and more high-fidelity, large-scale models. I want to show both, but on Ebola, a key model in this entire discussion has been the CDC Ebola Model. It is commendably explicit, and it was done under a lot of pressure, and I respect the people who built that model. It is, for those reasons, a very rudimentary model. The user has to supply 30 numbers or so per run of this model. So it really has more the flavor of an accounting tool than an actual dynamic model. And the assumptions implicit in it are that populations are well mixed, that there's really no space, that there's no behavioral adaptation, and as in a larger family of Ebola models, it produces a classical type of trajectory with a high peak and a fade out. And it heats up too fast and cools down too fast, in my view, as this general class of models does. Here's how it heats up. This is how the famous 1.4 million worst case scenario unfolds. We run this at our center. It's easy enough to run. The corrected word means that for every reported case, there are 2.5 unreported cases, which is a very high ratio that we'd like to bring down. David and others are working hard to do that. But the standard model, I'm afraid it's a little hard to see, the standard model heats up and then falls down, all right? That's how these models look qualitatively. I'm suggesting that this type of curve is more likely. We can avoid this huge peak with various measures, and behavioral adaptation can contribute a lot to the avoidance of that maximum. But then it will not die to zero. There will be an endemic level and endemic cycles of the disease for a variety of reasons. So there is a long-term prospect of Ebola persistence and a long-term management question that I think needs to be faced squarely. Why will this peak be less grave than the worst case? I think because prevalence of the disease will increase vigilance in complying with containment measures like personal hygiene, use of personal protective equipment, home decontamination, safer transportation to Ebola care units and treatment centers, improved burial practices. And I think, as David Peters mentioned, we're seeing this sort of change in LOFA in Liberia. And we have colleagues from Virginia Tech, Caitlin Rivers and Brian Lewis, who've, I think, documented that quite well with the data available. There is a containment challenge, of course, many containment challenges, but one of them is simply the healthcare workforce. It's hard to staff an operation of this scale with trusted, well-trained individuals. And trust is a huge factor. I mean, we remember that 8 healthcare workers were killed in Guinea, and that decontamination efforts were chased away in Sierra Leone because they were feared to be spreading the disseminating virus instead of decontaminating. So there's a lot of poor information, distrust to overcome. And I think that'll be important even when and if we have a vaccine. Polio vaccine is refused in Nigeria. Polio is resurgent in Nigeria because of distrust. So here's an idea of how to get a larger healthcare workforce. I've called this the MORE strategy, mobilization of recovereds. But I first heard the idea from Dr. Rich Rothman in our department, and now we've modeled it out a little bit at my Center for Advanced Modeling. The basic idea is, as far as we know, people who survive the disease are permanently immune. So let's train them and use them as a workforce in controlling the epidemic locally. And the arithmetic is pretty compelling, to completely back of the envelope. I mean, if you assume, I'm not assuming so, but posit 1 million cases, we have a case fatality rate of something like 70%. I hope we can reduce that. But, if you take those numbers, then you have 300,000 survivors with conferred immunity. So mobilize them as healthcare workers. They're immune to the disease, at least to the present variant. They're aware of the culture. They speak the language. They're trusted by others in their community. So let's convert them into a healthcare workforce. What potential impact could that have? Here's a very simple set of runs where we recycled recovereds into people who can reduce the transmission rate by improving these practices, training people, waste removal, all of these things. I know this looks a little bit daunting, but the basic idea is if you just take a classical standard model, the healthies fall, susceptibles fall, because they become infected. But then the infected pool falls as they die or are otherwise removed from circulation with none of this strategy, no mobilization of recovereds. If you mobilize the recovereds and run the same very simple run, you get a much, much higher, 20% improvement in the number of people who are healthy and a corresponding reduction in the number of people who die. And the peak is a tiny bit later, so it buys you a little bit of time also. So the blue curve under this strategy is 20% higher with 100% more mobilization of recovereds. And these are very conservative models. It's random mixing. It's not that these people are targeted as they should be. You would target them to communities. The model is just throwing them back into a pool. So it's a simple idea. What are the incentives? There could be communitarian incentives for people to do this. And as my always practical colleague, D.A. Henderson, reminded me in a phone call recently, you can also pay people to do things. Here's a methodological lesson, I think, of the exercise, is that here's a toy model that suggests a fruitful policy. It's simple, it's transparent. I'm not predicting anything. I'm not making any grand claims about the model. And I think there are lots of reasons other than prediction to build models. And if you're interested in that topic, for 16 reasons other than prediction, you might enjoy my little piece, Why Model, published recently, and you might enjoy taking our new spring course here at Hopkins. I encourage you to enroll. And I would say that I think Dr. Henderson would agree that we had good success building models that were simple and revealing and focused attention on important avenues, fruitful approaches, and so forth. And it disciplines the dialogue, as Ron Daniels was saying. It puts structure on the discussion. I think that's also important, especially in settings of this sort. All right. So I think these things can depress the spread, but I don't think Ebola will vanish for a bunch of reasons. One is ongoing viral evolution. Another is the persistence of animal reservoirs like bats and eating bushmeat and things like this. And there will be behavioral cycles of vigilance and complacency, even given a vaccine. On the first factor, why will it persist? Evolution. There's ongoing evolution in the virus. We've in fact seen, it's been around for a long time. This is the 76 strain, the first micrograph of the virus, starting in 1976. It's been around for a long time. These are different outbreaks by year in different countries, Congo and so forth. So it's not new. Why the spike now, and why is it suddenly urban? I think that's an interesting question. It's possible that this genetic variation is implicated. But I'm very interested in the work of Dr. Jonathan Epstein, no relation, who's focused on deforestation. And if you think about it, his argument is that this increases the vector density, and it does so non-linearly. If you reduce cover, land cover, from 10 by 10, let's say there's 10 by 10, to 9 by 9, you cut the area by almost 20%. So if it's the same number of bats retreating into a smaller area, the probability of contact with bats grows accordingly. So deforestation forces the reservoir to retreat, which increases its density, which increases the probability of contact with humans. And then roads, which is why we deforested in the first place to build roads, are lovely ways to transport these people into urban settings and their animals for sale and so forth. All right? So deforestation, here's Liberia. It's been this is a 5-kilometer scale, and you can see the whole area has been taken out. You can't quite see the colors very well, but the whole point of the deforestation is to build roads back into the cities. All right? So the mechanism then is you deforest and then to build roads that transport the things nicely into urban settings. And I thank Lauren Sauer for drawing my attention to the roads. Deforestation in Africa is, of course, a huge issue. It's going on everywhere, and, I think it's implicated in this. So recall my alternative curve. This is the classic curve, and this is what I was saying. We get this reduction, but we also get cycles for those reasons. But we also get cycles for a behavioral reason. And this is documented in work that I've published with Derek and John Parker and others, Derek Cummings here, and also in a recent book of mine, Agent Zero. But the idea is simply that if you take a vaccine, for example, this didn't come out properly, that should be is proportional to. But if you take a very simple picture and say the rate of vaccine acceptance is proportional to the level of infection, the growth rate in vaccine acceptance is proportional to the level of infection, but the rate of infection decreases with the level of vaccine, then you get oscillations. Very simple mechanism. So the basic idea, it's like yo-yo dieting, okay? It's the same idea. It's, I lose a bunch of weight, and so I get sloppy about my diet. And that makes me gain more weight. But then when I get heavy enough, I get serious about my diet again, and my vigilance increases, and you get cycles of vigilance and complacency in a huge number of spheres. But one of them is in vaccine uptake, and in, whoops, oh boy, what did I do? Did it. So, and the same with adherence to medications like statins and other things. So we see this sort of behavior typically. And if you imagine that vigilance in compliance with protocols, personal protective equipment, and so on, have this same behavior, then you do get oscillations, and that's just what we got in 1918. you got cycles of vigilance and complacency that produced ongoing outbreaks. And I think even with the advent of vaccine, especially in countries where there's a lot of skepticism, refusal, distrust, you can expect cycles of this sort. All right, this is what happened in 1918 in Chicago. We're practically out of the woods, and that was true. They were practically out of the woods, only a few infectives, but it only takes a few infectives to reignite the thing. So when you pour susceptibles onto those remaining infectives, you get outbursts. Okay, global spread. Let's talk about this, and then I'll wrap up. The incubation period is unfortunate for this. WHO statistics suggest that the average incubation period is something like 10 days. And that's bad news for global spread and for screening. I mean, the basic idea is, Joe gets infected in Liberia on Monday, goes to the airport Tuesday, he has no fever or other symptoms, so he passes the exit screen, lands in China, passes the entry screen, and, develops symptoms a week later. So screening is great, but it doesn't entirely contain the thing because of this incubation period during which you can pass screening. We have been using the global scale agent model. We at the center have developed, truly the only planetary scale agent-based infectious disease model. So Hopkins we have the only one of those. And it runs 6.5 billion individuals on a planetary transportation system. John Parker is the PI of that work, who's my senior software engineer. This is not a toy model, far from it, and it's been published in the Journal of Record for Machine Learning and also featured in Nature. Excuse me. And the thing about this model is that, there is randomness in the way things spread around the world. It's not, the runs of the model it's the so-called stochastic model, in which what the precise details of what happened differ run to run. So you start the thing with the same configuration each time. We're starting the runs with exactly the same infection situation we have in Africa, and then we run global transportation many, many times and try to build up a statistical portrait of how things spread. But among the things that the model generates, oddly enough, are spread to Spain. But it also has, again, that's one run of the model, one realization of a stochastic model. It also has runs where it get introduction in New York and introductions in Istanbul and introductions in lots of different places. So there are many possible trajectories, but introductions in developed countries are likely. Nobody running global models, and there are a couple groups, not all agent-based models, but that it would appear in Spain, that it may appear in Germany, that it would appear in the United States. That's not surprising to people who run these models. The numbers are huge. The number of people traveling is huge. And because of this incubation period, this screening is very porous. So, it's not shocking that you'll get cases in the developed world. In the United States, one of the things I think, sort of, what can I do? You can get a flu shot because that will cut the background noise of symptoms and help the clinicians do better, be more efficient in their treatment of actual Ebola cases. I mean, it'll amplify the Ebola signal-to-noise ratio. You don't want everybody with a sniffle coming in thinking they have Ebola. So prevent the sniffle and get the flu shot, and it'll help sort this out. Intermediate countries with high urban population density and low standards of public health are at highest risk, I would think, higher risk than certainly the developed countries. Just to wrap up, main points, I think the CDC worst case can be avoided. Simple models suggest that a strategy of mobilizing the recovered is a promising intervention, but Ebola is unlikely to disappear. Endemic cycles are probably going to continue as they have for 40 years, driven by ongoing evolution, persistence of animal reservoirs, and behavior. The cycles of complacency and vigilance, vaccine uptake, vaccine refusal, I think those will persist even when we have a vaccine. Incubation makes flight screening porous. I think it's important to do, but I think it's porous. Sustained US transmission strikes me as unlikely, but I think it's good to get a flu shot. Continued worldwide vigilance is essential. That's really what the global models say, is that everyone is at risk. Everyone is at risk. So all these countries should be vigilant. Just as the little comment on our team, the modeling team is a multi-school Hopkins group, immediately funded by UNICEF. That was David Peters was a lead in that. But it also involves direct collaboration with ministries of health in the region. I'm the PI for the modeling. David Peters is co-equal PI, Chair of International Health, Dr. Gabe Kellen, Chair of Emergency Medicine also. And I have lots of colleagues from all over the school, all over the university, a number of people from my center, Rich Rothman, Scott Levin, Lauren Sauer, Julia Chellin, other colleagues from elsewhere in the university, Derek Cummings. We do work closely with the Virginia Tech modeling team, Brian Lewis and Caitlin Rivers, and other people inside the university at APL and elsewhere. So I think Hopkins is and should be the flagship for modeling of global infectious disease and other global public health challenges. And we're building models at all these scales, but they are informed, I think, wonderfully by really great clinicians and epidemiologists, field practitioners, local governments, international NGOs. So Ebola is, I think we've stepped up, and it's allowing us to build an enduring multi-school infrastructure for global health challenges generally. I think that's one of the beneficial outcomes of meetings like this and crises like the one we are trying to deal with. So with all of that, I thank you very much.